I'm Cherian Verghese, Medical Director at Keystone Clinical Studies. Today we have the very great pleasure of having Dr. Salman Akhtar with us. He's Professor of Psychiatry at Thomas Jefferson. At a wider level, he's an internationally renowned author and psychoanalyst and a leader in the field of psychoanalysis. If you can give us a little bit about yourself, Dr. Akhtar. I know it's a lot to put in a few words.
Well, first and foremost, I'm a doctor, medical doctor, and then psychiatrist. And then after that, I did some training in psychoanalysis and have been involved in the profession of psychoanalysis and psychotherapy, largely. I'm also an author. I've written a bunch of books, actually slightly embarrassing number of books.
60?
71.
Okay.
It's an embarrassing number. But, the books that I've written are, some of them are actually unreadable, frankly, in all honesty. But the good books and meaningful books, there are two books on immigration.
Mm-hmm.
And
I read them.
Yeah, the profound impact that moving from one geographically and culturally distinct environment to another environment has on human identity, and then adjustment, and then subsequent raising of children, and so on and so forth. And the impact passes at least two generations.
Two generations.
Yeah, I think so. And so the two books on immigration, I think, are important books. One book on the synthesis of psychoanalytic literature and psychiatric literature in the area of personality disorders. That book.
And you're an expert on personality disorders.
Well,
that's your specialty.
Nobody should call themselves an expert.
Mm-hmm.
Others can call them expert, and one can feel flattered. But I've read a lot and written about it. And then I've also done books on those areas which my field, psychoanalysis, was not going into. So I had a choice either to break from psychoanalysis or to bring those areas into psychoanalysis. So I did a book on India. I did a book on the Islamic world. I did a book on the culture of Australian and New Zealand people. I did one book on African American people. I'm right now doing a book on Hispanic Americans. So culture and psychoanalysis. And then also something about the role of animals in human mind.
Right.
And such. So trying to bring more stuff in the field and to rejuvenate the field and give it more, broader scope.
And what's also interesting is many of your books are really about the human condition. Yes. And philosophical, if I may say so.
Yes, there's a book called Matters of Life and Death where there's a 40-page chapter on graves and the significance of graves. Both personal significance, the significance in mourning, grave addiction, grave phobia, and then political uses of graves. Taj Mahal, the biggest beautiful structure we have in India, is basically a mausoleum and a grave. And then how in various political conflicts, destruction of graves becomes a very important matter and such.
And they become a rallying symbol for arousing people's anger and a sense of revenge.
Yes, indeed. That's what, Yugoslavia split up by, that was not the reason, but the method was to evoke a particular grave.
The Battle of...
with Salazar.
Sarajevo.
Battle of Sarajevo. Mm-hmm. There are patients in grief who do not need treatment, and there are patients in grief who need treatment, and others will know.
All the changes that we have gone through in the field of psychiatry and mental health services, the average person on the street would ask the question, who do I go to? When do I go to see a psychiatrist, my family doctor, or go to a psychotherapist, or at the top of that chain I would say would be a psychoanalyst. So where would you see, the services of a psychoanalyst or a psychotherapist come in?
See, I must say I disagree with you on one thing, and that is, it's not that psychoanalyst is on the top of the chain, because each modality that you mentioned is of actually considerable significance and perhaps equal significance. There are patients who will need medications. There's absolutely no doubt about it. And whether the medications work or not work, but sometimes they do. But the predominant intervention should be medication. Suppose somebody is psychotic. hallucinating, wandering on the streets, behaving in a very odd and strange fashion, and on surface quite disturbed, and internally quite frightened and quite distressed. And if the disturbance is of that proportion, you know more about this than I do. Obviously, this kind of person will need medication. There are people who are stuporous, lying in bed, unable to get up, do anything, cry the whole day, lose weight, and such. They might be in need of electric shock treatment.
Correct.
It only appears in some movie version of it, and Bollywood and Hollywood version of it as primitive. I think it can sometimes be very useful. Same thing applies to
ECT, you mean? Electroconvulsive.
Yes, of
yes,
course.
I would agree with you. It's a very underused modality.
In severe depression.
Correct.
And in catatonia, etc. Yeah.
And just like you would shock your heart when it stops,
exactly,
you may need to shock your brain and bring it back to functioning.
That's a good way to put it, to explain this matter. So I think that each modality has its own place. Then when we move to the world of psychotherapy, even there, there's more cognitive and behavioral oriented treatments that are useful for focal conditions. A person says, I'm terrified of flying in planes. Otherwise, the person is happily married, is a responsible man or woman, has a job, is a good father or mother, but there's one symptom.
Like a phobia.
Yeah, so that kind of condition, I don't think needs more detailed and intensive long-term psychotherapy. That kind of condition, I think, is much better treated with behavioral interventions and such. Focal interventions, specific phobias and such. The kind of conditions that require psychotherapy and psychoanalysis, and if you want, I'll go into the distinction.
Sure.
But I think that there what we require is a reasonable person, honest, hardworking, with a record of perseverance, with absence of serious mental illness,
major psychosis,
and addiction, and serious lying and cheating and such. If that is not there, the person is reasonably integrated but has a big problem, not a small problem.
So it should be big enough to warrant the effort that goes into it.
Yes, big problem. Let's suppose a lawyer comes to me and says, I've been married once, and I married somebody far beneath my socio-economic and intellectual status, and I sort of wanted to help that woman. And then, after 2 years or so, I said, what the hell have I done? So I got divorced. And then I somehow fell in love with the woman who was seriously mentally ill. And I started taking care of her, and I got very involved with her, and I got married to her. And then I realized, oh my God, what have I done? So I got divorced. And the third time I married a woman who was extremely obese, morbidly obese, and pretty much homebound. And now I got divorced. Now I'm falling in love with a woman who has, bilateral amputee. And I begin to realize that there's something in me.
Pattern of repetition.
And something in me. Now this person is not a candidate for medication or behavioral therapy.
Sure.
This person requires psychoanalysis. Because their problem is deep, is repetitive and life-destroying. And yet the person is otherwise integrated and a strong structure. So it's one of those things. It's like going in a coal mine. You've got to have a good elevator and a proper shaft and an alternative generator system. Then you can go in coal mine to look for diamonds. But if there's a wobbly structure, you don't want to go in there.
And the coal mine is the person
in the dark and deep corners of the mind that the person is not aware. For example, this hypothetical patient I made up is not aware of why is he doing this. He's just driven and compelled to do this. And what is compelling him is out of his awareness.
So it is exploring with that person, going down into that coal mine, as it were, together, in a safe way, to find out it's not diamonds we're looking for, but some very bad gas.
Yes. In effect, that's why one of the cardinal beginning gambit of any psychotherapy is to tell the patient, why don't we look into this matter that is troubling you? We look into the matter that's troubling you.
So it's together.
Yeah, right, togetherness. Therefore, you already require a person who's able to play along and has the mind of that set. And and it is a collaborative effort towards solving a person's
So
problem.
it's the other end of surgery where it is done to you
That's well
and you are
said.
anesthetized.
Except that sometimes in psychoanalysis and surgery there is a common element. Both people are lying down.
So Dr. Akhtar, how would a person who goes to a psychoanalyst or even a psychotherapist get a sense for, is this right for me? Is this something that could potentially work for me? Because they're making a big commitment in terms of time and money and the opportunity cost.
See, I think two things have to happen in the first interview. Very first interview, two things must happen. One thing is a sense of affinity must develop, meaning that the patient must feel that you and I, the doctor and the patient, are roughly in the same boat. So that now it's easy for you and me to have an affinity. Suppose I get very depressed and I come to you and I said, Dr. Verghese, you know about medications, what should I take? Tell me. You treat me with respect. I'll treat you with respect. You know I'm a doctor, I know you're a doctor. So we are roughly in the same boat. And the affinity is built in. A medical student comes, an affinity is built in. A lawyer, a professor comes, a certain amount of cultural, intellectual affinity is built in. When it is not there, then it's our job to build. For example, I'll give you one example. Let's suppose a patient comes from a culture that you have no idea about. A patient comes and you cannot even pronounce his name. He tells some name. I think it's always good to say, excuse me, could you tell me how your name is pronounced? Rather than just making it up. Yeah. Or you could say, look, can you say it slowly because I'll try to say it with you? You could say, I may not be able to pronounce it as well, but I'll keep my mind open and try. That is building affinity. Or a patient comes from a country you have never ever been to and don't know anything about. Patient says, I'm from Sierra Leone. Now you have a vague sense that Sierra Leone is in Africa, most likely on the west side. So you say, let me tell you one thing. Before we begin about your problems, I don't really know much about Sierra Leone. Can you just either draw a map for me or tell me where it's about? Because I want to locate. And what is the capital? I don't know the capital of Sierra Leone.
So that's a very interesting way you do it, because you put them in charge.
Yes.
And confess your own...
Exactly. So you have to, when there's no affinity, then it's your job to go down and make the affinity. I tell you, one time I had severe shoulder pain. And I went to a rheumatologist, and because I'm saying good things about him, therefore I'll take his name. He's passed away. His name was Nathan Smuckler. He was actually he started the rheumatology division at Jefferson. And I had very severe pain in my shoulder. And I took off my jacket, my shirt, my undershirt. I'm sitting, he's examining me. As he is examining me, and I'm in pain, and he's doing his job, he says to me, completely nonchalantly, completely non-manipulatively, Dr. Akhtar, what is your sense? Is this theory that Freud had about dreams, is this actually currently valid or not? Or is this going to last, or is it going to be discarded? Now, as he said that to me, I suddenly started feeling, rather than a little boy in pain, half-naked man in pain, I started feeling a dignified person.
You know what we call that?
Yeah.
Vocal anesthesia.
Yeah. But it's, so I think that's one thing that has to happen in the first session. The patient must get feeling that you're not looking down.
So he did the same thing in a sense, put you in the...
Raised me up, and therefore we were both fellow human beings now. He knew about shoulder joints, I knew about Freud's theory of dreams, right? So in that way, he brought me up, especially because he's dressed, he's wearing a suit,
Right.
I'm sitting half naked. So in that moment, I think it was not manipulated. I think it was built in. Yes.
So you try to find some area of affinity with the patient.
Yeah, and if you come, it'll be done in 50 seconds.
Correct.
If I come to you, it's done in 50 seconds. With others, you have to spend a little time to create this thing.
Working.
Patient must get a feeling. For example, patients sometimes ask, you ask the patient, are you feeling suicidal? Let's suppose there's a patient who's caustic and sarcastic. He might say, how about you, Dr. Verghese? Have you ever felt suicidal? I think I struggled with this for years, and finally I think I found the right answer. The right answer is that, look, I'm a human being, and all human beings
Go through that.
have thoughts of suicide from time to time, but in the acute and clinically relevant and dangerous way that I'm investigating right now with you, I have not felt it so far. The key word is so far. In that way, you keep with the patient. You don't say, I'm above you, I'm with you. So anyway.
So also the acute and clinically relevant,
Yeah,
it is.
meaning passing thoughts, who doesn't have? Everybody has. So that same thing with homicide. Who doesn't have? I can give you a list of 7 people. I'll walk one dead. But I'm not going to kill them. So that's one piece, affinity. The second piece I think that the patient must get, and that is regardless of whether it's a pharmacologist, psychopharmacologist, psychotherapist, psychoanalyst, CBT person, or whatever. The second thing the patient has to get is a sense of authority. Not authoritarianness, but a sense of authority.
Your own authority.
Yes, the doctor.
Okay. That you know.
That you know what you do.
Okay.
You know what you're doing. That you are confident and you're not. See, here is an example. When I came to this country in 1973, patients used to ask me all the time, where are you from? Where did you go to medical school? Where did you grow up? Where did you was your education? Not a single patient ever asked me now. Never. And the reasons are 3, I think. One, because the country has changed.
Country has changed.
So
there are so many doctors of Indian origin.
So there's not an esoteric thing anymore. 2, my patient population has changed. So I'm dealing with more educated people, etc., and affluent people. But I think even those 2 factors do not account. What ultimately accounts is that I've become a better doctor. Because the patient doesn't care whether you're brown, black, Chinese, or Jewish, or Christian, or Palestinian. The patient doesn't give a damn. The patient is not there for you. The patient is there for themselves. So when the patient feels ununderstood, then says, so where did you go to medical school?
So you're saying that in some ways you convey a sense of authority.
Yes, that I've become a better doctor. I've become a better doctor. That's what the patient must get. The patient must get a feeling, in my field of psychotherapy and psychoanalysis, that the patient is being listened to in a new way. Listened to in a new way. That's the patient must get.
And that happens at a very unconscious, subconscious level. It's not verbal.
The kind of questions you ask, the theme that you pick up in talking, etc., etc. They're being listened to in a particular way. Just take this example where when we started this interview, I entered the room and there were 2 chairs. And I said, I'll sit on this side. And your brother said, how can we pick this chair? Now, that is being listened to, right? So I felt that, wow, that's good. Somebody's observing this, somebody's taking it seriously. And that's what the patient must get. And there might be different ways. A pharmacologist may ask different questions, a psychoanalyst may ask different questions. But the patient has to get a feeling that the doctor knows what he's doing. And that he's seriously interested in me and has knowledge. If that is convinced and affinity is built, every patient will come back.
So then you're on a roll from there.
Yes.